One thing that we have done is to test this device across all patient subsets and all anatomies. So instead of picking the patients for the study, we really looked at the all-comer population. And why this was, one can say, a high-risk option to do that, we really tested the device down in every, or in almost every clinical situation, in almost every anatomic situation that the device may be required to perform in. This allowed us to look at both symptomatic and asymptomatic patients, patients with challenging access anatomies, patients with challenging lesion morphologies such as thrombus-containing lesions, and also patients with string sign stenosis. So we've covered the whole spectrum of patients and lesions that can be addressed with, that can be treated with carotid artery stenting today. And I think what is really also important is the fact that we have used different protection devices. Really the only difference between your procedure within CARENA, within the CARENET consecutive patients and those before, being that you pick up a different stent from the shelf. Otherwise, you do everything as usual. So now we generated a body of evidence, a body of knowledge that tells us that the device can be used, again, in different patient populations, across different anatomies, in complex lesion morphologies, and in difficult access anatomies. So one of the important phenomena when it comes to the interface of carotid plaque and carotid plaque sealing with the device is that the neurological events are not limited to the time of the procedure. Protection device would not eliminate the risk of brain embolization during the procedure. It would reduce it, but it would not eliminate it. What happens after you place the stent in the carotid artery? And we know this from both some angiographic images, but also from intravascular imaging, that a significant proportion of patients would have this cheese grater effect or plaque protrusion through the stent struts. There is data from MRI imaging of the brain that show that there is this phenomenon of new lesions in the brain that occur in the hours after the procedure. Another line of evidence is the line generated by Dr. Bossiers, showing that more than 50% of the neurologic events after the carotid stenting procedure occur not in the cath lab, but when the patient leaves the cath lab. And interestingly, those events occur within the first approximately 30 days. And it's very likely that some of those events, if not majority of those, would be related to plaque protrusion and then mobilization of embolic material. And not only that, once you have a protruding plaque, there's also a risk of new thrombus formation on this disturbed plaque. We were pleasantly surprised, I have to say, with the very limited, that's next to zero, the new diffusion-weighted imaging ischemic foci in the brain. I think that's one of the most fantastic features of this device. A conventional stance, the smaller the cell size, the more stiff the device is. On the other hand, when we want to use the stent that would nicely conform to the anatomy, the stent needs to be an open cell stent. Then the cell size is really large, and the risk of plaque protrusion and embolization is large. CGuard has the properties of both as close cell a stent as possible on the one hand, and on the other hand, it's as open as possible by the way it can adjust to the anatomy. Importantly, I think you can allow yourself more liberty in the degree of post-dilation. This quite aggressive post-dilation. There were so few hits on DWI when it comes to the brain lesions. So we know that the stent really does trap the embolic material between the mesh and the wall of the artery. So some people are concerned, is it really a bulky device? Will I be able to deliver it easily? Will direct stenting be feasible? The device is a bit more bulky than some other stents, but this in no way changes the way you perform the procedure. I think one other area we have challenged the device is the preciseness or respective preciseness of the placement. And we have quite a few examples in the carnet population that demonstrate that the placement of the device is extremely predictable, so we get it exactly where you want, and we have not noticed any foreshortening of the stand. So the stand lands up where you want it to land. I think it's a tremendously exciting time now. This is something that the community had been waiting for at least a decade. It has happened now. We have a new tool in our hand that is a safe tool. The main question is, when is it going to be available?